everybody, and welcome back to the CAMPPODS. It is my pleasure to welcome you as of right now, 60 participants out of the 125 that signed up for today's CAMPPODS. And I think we're going to have a great session today. I will start, as always, going through some housekeeping slides. I will remind you the overall learning objective for CAMPPODS. We would like to establish a strong Canadian oncology education network, although I keep saying that I have to change this learning objective to more of a strong oncology education network, given that we have participants from 8 countries. We would like to compare ideas and thoughts and common challenges, and to identify gaps and find solutions for improving patient care. And also, one of the main learning objectives is to really learn to work together and integrate pathology and oncology practices. CAMPPODS wouldn't be possible without the help of our sponsors, so I would like to acknowledge them in alphabetical order. Thank you, Amgen, AstraZeneca, Bayer Healthcare, Bristol Myers Squibb, Merck, and Pfizer for supporting the 10 CAMPPODS for 2021. Next slide, please. Some housekeeping rules. Please have your microphone and video turned off throughout the presentation. And you can see both icons should have this red line indicated that they are off. To ask a question, please use the question and answer session, but send us your questions in the chat. Make sure that you submit the questions to all panelists. And if you do decide that you would like to chat privately with some of the participants, you are welcome to do so. I would like to remind you that this session is recorded, and therefore all the chats are part of the recording. So please be careful of what you're saying. For the best viewing option, we recommend that you set your screen to view by clicking the view icon located on the top right corner of your screen. And without further ado, I would like to introduce today's topic, molecular subtyping of urothelial carcinoma, pathological correlation and clinical impact. And today we have 2 distinguished colleagues from University of British Columbia, Dr. Peter Black and Dr. Gang Wang. I would introduce them one by one. So I will start with Dr. Peter Black, who is a surgeon scientist, a senior research scientist at the Vancouver Prostate Cancer Center, associate director, clinical research at Vancouver Prostate Center, professor in the Department of Urological Services at University of British Columbia, and has a clinical subspecialty interest in the treatment of urologic cancers, including especially bladder and prostate cancer. Dr. Black maintains a grant-funded translational research program in urothelial carcinoma with a focus on genomic analysis of response to chemotherapy, mechanisms of resistance to chemotherapy, and novel target therapies for bladder cancer. Among the many awards that Dr. Black has received, I would like to mention the David A. Swanson Distinguished Alumnus Award from MD Anderson Cancer Center, which he received in 2017. And I think that that makes a bridge to me introducing my colleague, Dr. Gang Wang, who also has his subspecialty training in GU pathology, also done an MD Anderson. So Dr. Gang Wang is a consultant pathologist at BC Cancer. His office is actually right behind that wall. He's a clinical assistant professor of pathology at University of British Columbia. And Gang started his career at University of British Columbia through a PhD degree, followed by a residency training, which he started first at Case Western University in Cleveland. And after a year, he came back and joined us at University of British Columbia, being one of my residents. Following his fellowship at MD Anderson, Dr. Wang joined us as a consultant pathologist at BC Cancer Agency in Vancouver. And his research focus is in malignancies of the genitourinary system, but he's also interested in molecular studies in different tumors, including breast and lung cancer. So without postponing this interesting presentation, I would like to invite first Dr. Wang to start talking about the molecular subtyping of urothelial carcinoma. Yang?
Good morning, everyone. Can you hear me clear?
Yes.
Okay.
Yes, Dr. Wang, can you just turn your camera on?
It says cannot start video because the host has stopped it. All right. Sorry. All right. Good morning, everyone. So I'm going to start with the this morning's talk by histological variants of urothelial carcinoma. Next, please. Yeah, next. So here's the list of histological variants of urothelial carcinoma in the current WHO classification of urinary tumor. So it includes the morphology defined nest variant, macrocystic variant, and the micropapillary variant, and also the tumor which mimic the tumor from the other side, such as the urothelial carcinoma with squamous differentiation, glandular differentiation. So we're going to focus on some of the behavior aggressive variants, which is included in this list. Next, please. So we start with the nested variant. So it's defined by the small nest of urothelial neoplastic proliferation. And those tumor cells has minimal cytological atypia and arranged with a haphazard small nest penetrating into the deep of the stroma. But since this variant doesn't have, most of the time doesn't have significant stroma response, and also no significant cytologic atypia. So sometimes it will cause a diagnostic difficulty. Next, please. Especially in the superficial biopsy, and such as in this view. So in, in the right lower show the normal urothelial lining, and within the superficial laminar propria, there is a small nest of proliferation urothelial cells with not much cytologic atypia and no stromal response. So it's hard to tell whether it is a membrane nest or it's a neoplastic process. Next, please. But when we look at the whole picture and see those small nests penetrating or infiltrate into the deep stroma, so and we can start to appreciate the invasive behavior nature of this lesion. Next. Especially when we see the tumor infiltrating into the thick, smooth muscle, we call it muscular propria, we can say this is a really aggressive, sneaky tumor. Next, please. The large nested variant is some special nested variant. It has similar clinical behavior versus a small nested, and just have a larger nest. Because the same as the small nested variant, there's not much cytologic atypia, and also most of the time doesn't have the stromal response. So in the superficial biopsy, it's really hard to tell difference between this tumor versus the cystitis cystica or glandularis. Next, please. Macrocystic variant, we consider as a special type of nested variant. It has a similar behavior, but it just has a cystic change within the small nest. Again, in the superficial biopsy, it's hard to tell whether this is a cystitis cystica or a tumor. So until we see the whole picture and see the tumor infiltrating deep in the stroma, and we can appreciate this behavior as aggressive behavior. Next, please. Next will be very special type and plasmacytoid variant. This tumor mimic the morphology of plasmacyte. So the tumor shows a little discohesive with eccentric nuclei, so mimic the plasmacyte. And the tumor can be generally sheath-like growth pattern, but in the front line of the tumor, usually very infiltrative. Next, please. And from this view, at the low power, we can see the right lower corner shows like a single cell pattern of infiltrating into the smooth muscle, muscular scorpia. So that's the tumor, is a T2 tumor. And then before we move on to the next slide, and we will may or may not notice, and this is the left upper corner, this is something a little bit unusual. Next, please. Here is to highlight the area we are focused on. We will zoom in this area. Next slide, please. Yeah, here and the further zoom in. Next, please. Can see it in the center in this space. And there's a cluster, probably 6 atypical cells within this space. Compared to the left side of those benign lymphocytes or plasmacytes. So those tumors have a relatively larger size and larger nuclei, hyperchromasia, and also have the irregular nuclear contour. So this is has apparent cytologic atypia. So this is the tumor cells, and since those cells are within, seems like within the lumen, and also adjacent red blood cells around there. So it's most likely it's in the vascular space, lymphovascular invasion. So obviously we need to prove it, this site, if we prove it's a surrounding endothelial cells, so it will be lymphovascular invasion. If not, so there'll be a T3 tumor, which is easily got missed from the low power view. Next. This is another picture of plasmacytoid variants of urothelial carcinoma infiltrating the perivesical adipose tissue, is T3 tumor, compared to the right upper corner of those benign lymphocytes, and those cells are apparently larger size and has a cytologic atypia. Next. Micropapillary variants is another type of aggressive urothelial carcinoma. But by morphologically diagnostic criteria is the more than 5 small clusters of tumor cells within the same locus space. So that's the usually adapted diagnostic criteria for this variant. And this variant is very often, most of the time, will have associated with an lymphovascular invasion and the distant metastasis. So it's also another aggressive tumor. Next. This is a sarcomatoid urothelial carcinoma. So this is a low power view, has obviously a typical spindle cell proliferation. Next. In the high power, clearly the bizarre tumor cells. And the first look is will be impression of sarcoma. So this is a kind of a little bit subjective diagnostic criteria. When you see the tumor, the first impression it will be like a sarcoma. So it probably is a urothelial carcinoma. Next. quite often, but not necessary. And the sarcomatoid urothelial carcinoma will have a heterologous component, such as in this picture, it shows the tumor cells making the bone matrix. But it's not, it is most of the time has it, but not diagnosticated. Next. It's quite often, and the urothelial carcinoma will have a squamous differentiation, and show this picture with keratin production in the center highlighted by the arrow. Next. And also quite often has a glandular differentiation. If it's a whole tumor is a glandular differentiation, we can call it a primary adenocarcinoma of the bladder. But if it's associated with conventional urothelial carcinoma, and then we will call urothelial carcinoma with a glandular differentiation. It all depends on how much this glandular component. And sometimes it has a large branching glands formation, well-formed gland. Next. And sometimes it's those are smaller and poorly formed glands. Next. So let's move on to the small cell carcinoma, because small cell carcinoma has a different systemic therapy regimen than the conventional urothelial carcinoma. So it's quite important to recognize it and look at it. So this is the left side. This is a low power view of this tumor, and it has clearly quite blue. In the right hand side, there's a high power of this tumor, has a nuclear molding, mitosis, and necrosis, and as well as so sometimes we can see the pseudo-rosette. Next, please. And yeah, keep going. Next. 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 Large cell neuroendocrine carcinoma is really rare, and especially pure large cell neuroendocrine carcinoma. It's really rare in the bladder. So here's the one of the example of a relatively well differentiated. So the tumor arranged into the large nodular or nest trabecular growth pattern. The sign of neuroendocrine differentiation is demonstrated by the peripheral panocyting, and also has those scattered pseudo-rosette. We can appreciate in this picture. Next. But some of the other large cell neuroendocrine carcinoma shows poorly differentiated and with very infiltrative growth pattern, such as this demonstrated in this view. But still, sometimes we can see the pseudo-rosette in the right side of the picture. Next. Sometimes the large cell neuroendocrine carcinoma mixed with small cell neuroendocrine carcinoma. So in this picture, in the same view, left side is shows a small cell carcinoma, and the right side is a large cell neuroendocrine carcinoma. And we will go back to this picture later on. Next, please. So that's about the introduction of the histological variants of urothelial carcinoma. Let's move on to the molecular subtypes, and Dr. Peter Black will discuss it. Peter.
Thank you, Gang. Taylor, I also cannot turn on my video. If you can do that for me, please. I would, there we go. Diana, thank you for the invitation to take part in today's session, and it's a pleasure to share the Zoom podium with Gang. We are doing more and more research projects together, and of course, it's great to have a bladder-focused pathologist in the community. So I'm going to talk about molecular subtypes, which of course we would consider as building on the histology. Gang has talked a lot about the different histologic subtypes that are certainly very relevant to us in our clinical decision-making. Molecular subtypes will be very familiar to you from other cancer settings, especially breast, but in bladder cancer, we're usually playing catch up, and we have caught up a lot in the last few years. The idea of subtyping bladder cancer based on RNA expression It really came out of this 2012 publication from a group in Lund, Sweden. They describe a molecular taxonomy, but it wasn't until the TCGA paper on bladder cancer, the first paper came out in 2014, that it actually caught people's attention. And they divided bladder cancer into 4 different subtypes that they didn't actually name, they just gave them numbers. And within a month, there were 2 additional papers, one from UNC that compared it to the bladder cancer, let me just go back there for a second, to breast cancer subtyping, which was familiar to everyone and therefore really made it more understandable, I think. And then the group from MD Anderson, where both Gang and I did fellowships, they put it in the context of sensitivity to chemotherapy, which gave it immediate potential clinical utility. And since 2014, since these papers were published, it has been a sort of framework within we study a lot of different aspects of bladder cancer biology. The general premise will be very familiar to you. The big divide is, of course, between basal and luminal, and the luminal tumors have a gene expression pattern that is similar to the luminal, more differentiated layer of the urothelium, whereas basal tumors have a gene expression pattern that's more similar to the basal layer of the normal urothelium. And the group at UNC immediately came up just with this dichotomous division into luminal and basal, and you can see, high basal gene expression in about 1/3, and high luminal in about 2/3. The group at MD Anderson, I'm just giving a couple of examples here. There are 5 different systems, but the group at MD Anderson added a 3rd group. You can see at the top again we have a group with very high basal gene expression. In the middle, a group with very high luminal expression, but in a group at the bottom that doesn't have a lot of basal and doesn't have a lot of luminal, but has a very high level of stromal gene expression. This was referred to as the P53-like subtype. Nothing to do with P53 mutations, but it is a gene expression pattern consistent with activation of P53, so more of a senescence pattern. And these were the ones that were resistant to chemotherapy, which we'll come back to later. So there are 5 different systems. All the different players involved in the field got together and came up with a consensus classification to try and move the field forward all in one page. And in the consensus classification, there are now 6 subtypes. And you'll see there are 3 different luminal subtypes on the left. There's a stroma rich, which is similar to the P53-like that I described. There's the basal in red, and then in purple over on the right side is this neuroendocrine-like. And I'll go into a little bit more detail about it. But these are conventional urothelial tumors, urothelial carcinoma tumors. And within that, you have a subset of patients with a neuroendocrine-like gene expression. The luminals tend to have the better prognosis. If you look at the very left-hand side, the luminal papillary, they are the most common, they and basal are the most common. They're characterized by FGFR3 alterations, which of course are very common in general in bladder cancer, and also PPAR gamma activation. I won't go into detail in the others. Actually, I'm just go back for 1 second, just to highlight that the micropapillary variant, the histologic micropapillary variant, fits into this luminal non-specified. The luminal unstable, the unstable refers to the genome, so they have a high mutational burden. There's some indication that they may respond better to immunotherapy. And then the other 3 types, as I mentioned, let me just go ahead here. I'm going to focus a little bit on the neuroendocrine like subtype, just as an example of potential clinical utility, since Gang has just finished talking about the histologic variants. And the idea here is that we have the obviously neuroendocrine tumors by histology, and the obviously conventional urothelial tumors by histology and gene expression. But in the middle, there are those that look like urothelial carcinoma but have a neuroendocrine gene expression. And is this potentially a transition state? So we looked first at the TCGA data set, and this is, we developed a very stringent classifier that basically excludes basal and luminal tumors and hones in at the bottom here on the neuroendocrine genes. And you can see some of the typical things like PEG10, chromogranin B is actually there, synaptophysin. So dark blue are the ones that we're calling neuroendocrine based on the classifier that we developed. Light blue is the TCGA classifier, which is a little bit broader and includes other patients. But the big message here is just look how poorly they do. So the neuroendocrine-like tumors really have a very poor prognosis compared to the overall cohort. And so we looked at this in several other different cohorts. We have a cohort of patients who received neoadjuvant chemotherapy. You can see that only 3 out of 223 patients had this neuroendocrine-like subtype. A group that had cystectomy alone, and a group that underwent chemoradiation, or a few more in this group for whatever reason, so 9 out of 136. And if we look at the, oh, actually, let me show you this first. So we have, here we actually looked, we had a subset from these different cohorts. We're able to get tissue from a subset of patients. And we have, first of all, just 4 different patients not part of this who actually have true neuroendocrine tumors. And we looked at some of the typical immunohistochemical markers. But then we were able to get, I think it's 9 patients, 8 or 9 patients here, that were conventional urothelial, but had the neuroendocrine gene expression. And you can see that at the protein level, they're also definitely neuroendocrine. The chromogranin A in the middle here is perhaps a bit of an exception. And so if we look at the outcomes of these 3 different cohorts, you can again see with neoadjuvant chemotherapy, there's only 3 patients, but they did horribly. Cystectomy alone, they did very poorly. Chemoradiation, 9 patients, interestingly, did almost as well as the rest. So does that mean these patients should be preferentially treated with chemoradiation? It's impossible to say with such low numbers, but it raises that hypothesis. And then if we look at IMvigor210, which is a clinical trial testing atezolizumab, so one of the PD-L1 inhibitors. This is a single-arm trial, so it's there's no comparison to, for example, just chemotherapy. But if you look at the different subtypes and their response, so complete response, partial response, stable disease, or progressive disease, you can see that what they were calling neuronal, what we call neuroendocrine-like, they all responded. So that it was 100%, 8 out of 8, either complete response or most of them were partial response, compared to an overall response rate of about 20%. And then from a survival point of view, they also did well. Of course, I should say this is in the metastatic second-line setting, but very interesting that these patients could potentially do better with immunotherapy. Does not necessarily align with what we know about neuroendocrine tumors in other sites. Taylor, my ability to advance slides just disappeared. Okay, perfect. So in summary, just on this part, I think that the neuroendocrine-like subtype demonstrates the power of molecular classification and potential clinical implementations. You could imagine this also being relevant for other subtypes, for example, micropapillary or plasmacytoid. It'll be important for characterizing the biology of these tumors and potentially for developing rational therapies. But I think for now, we still struggle also to identify them based on histologic criteria, and there's a lot of inter-observer variability, and so the genomics could certainly help there. And I'll come back, and next slide, please. I'll come back after Gang has spoken a little bit more about the pathological correlations of these subtypes, and I'll go into a little bit more detail about some of the potential clinical implications with respect to chemotherapy. Over to you, Gang.
Thank you. And next. Yeah, so let's start with just Peter discussed the neuroendocrine type of urothelial carcinoma. And so we started with the small cell. So what we do as a anatomic pathologist in our daily practice is we look at the morphology and try to figure out what the type of tumor by the immunohistochemistry. So that's what we do. And just so we focus on those things and correlation with the subtyping. So for the small cell carcinoma, usually they have a variable expression of beta-carotene, which shows the left, and most of the, I would say, in all the cases I see in small cell carcinoma is negative for GATA3, which is shows in the right side of the slide, and compared to the conventional urothelial carcinoma in the lower corner of those picture. Next, please. And the small cell carcinoma has negative for CK20 staining compared to the urothelial carcinoma with a glandular differentiation, and also those small cells obviously express the neuroendocrine markers such as chromoguanine synaptizing, TTF1, and insulin molecules. Modules INS and INSM1. And this is a new marker for the neuroendocrine carcinoma. Next. So this is the summary of immunopattern for small cell carcinoma. So basically, this is a positive for neuroendocrine markers, variable expression for cytokeratin, and negative for GATA3. It's sounds like it's not a full. It's not a whole table here. But anyway, I'll explain. And so they will have some, should have some more markers listed here, and such as an active for GATA3. Next, please. So compared to the small cell carcinoma, the large cell neuroendocrine carcinoma will have a variable expression pattern for GATA3 from completely negative in the right and to patchy or focal positive in the middle to the diffuse positive demonstrated in the right. Next, please. And here's a summary of the immunopattern for the large cell neuroendocrine carcinoma. Again, most of the cases will express two or more two or more neuroendocrine marker, and also variable, most of the time positive for cytokeratin, and the variable GATA3 expression. And here is an example of a different staining pattern of CK7 in small cell carcinoma and large cell neuroendocrine carcinoma. In the left picture, we have shown before, and as a combined small cell and large cell, we can see those small cell has basically negative or characteristic dot-like cytoplasmic staining pattern, while in the large cell neuroendocrine carcinoma has a strongly positive for CK7 usually. Next. For the plasmacytoid variants of urothelial carcinoma is defined by the molecular change of the ecdyrin gene. So there were either lost expression or it has a variant expression of ecdyrin, which is shown here. And compared to the upper side of the imaging, so diffuse positive ecdyrin staining in the normal urothelial, the down part, the downside of the picture, which is infiltrating plasmacytoid tumor, has lost expression of ecdyrin. Next. People also try to characterize the immunopattern for other clinical aggressive behavior variants of urothelial carcinoma. So here's this example of nested variant. People find the peripheral staining pattern of CK56 in the nested variant of urothelial carcinoma, but another half of the case has a variable pattern or intensity of the CK56. So it's not very specific or sensitive. Next. As for the micropapillary variant, and so we now know that it belongs to the nominal type of urothelial carcinoma, and demonstrated by the positive GATA3 staining and negative CK56. It also shows approximately half or less than half of the cases has a mutated p53 status, which shows in the left corner is the diffuse pattern. In the right corner is a loss expression pattern of p53. Next. However, we see the percentage of the cases, and this is 40% of the cases have p53, but we now know that p53 mutation is not an uncommon findings in the general conventional urothelial carcinoma. So this result is not a specific or sensitive way to identify those as well. Next. So right now, the main focus was an anatomic pathologist and is still focused on tell apart the luminal type versus the basal type. So the luminal type markers, including the GATA3, CK20, and uroplakin. The basal type, including the CK56 and the CK14. So that's the marker people usually use. Next. But when we define as a negative staining versus a positive staining, so we can see this is a variable staining for each of the markers. And none of them are very both specific or sensitive. Next. So right now, the effort will be focused on using the as few as markers to do the job. So the Anderson group are using the 2-marker panel, which is a GATA3 and CK56 as a simple classifier to tell luminal versus the basal. And here is a luminal has a strongly positive staining for GATA3, negative staining for or focal staining or weak staining for CK56, while the basal type will be negative staining or weak staining for GATA3 and positive staining for CK56. So the performance of this 2-marker panel will have effective in over 80% of the cases. And so in our study, in our institution, we try to using a single marker. How we use it? Can we use a single marker to do the job the same thing? Since if we call the particular marker positive or negative, none of not gonna work well. So we think so maybe we can give a score like we do in HER2 immuno for breast and the PD-L1 in the other tumor. Next. So the candidates we are chosen is the uroplakin 2, which is a luminal marker. But we know it is very specific marker for urothelial carcinoma, and but it's not sensitive. So, but the cases, the percentage of the positive for overall urothelial carcinoma is about 70 to 80%. So, but when you use the pure positive or negative, won't do the work well. So we try to focus on the scoring. The scoring algorithm we're using is similar as PD-L1. 3+ is 50% or more tumor cell staining. 2+ is 10 to 50% of tumor cell staining. 1+ is 1 to 10% tumor cell staining, and 0 is less than 1, basically no or almost no staining. And the tumor cohort in TMA we used is from the cohort of muscle invasive urothelial carcinoma, because this is more clinical relevant, and most of the cases are likely to have a systemic therapy. Next. So all the tumor in this cohort will have gene expression data available, has designated as a molecular subtype based on the gene expression data. So here's the data we have. And so we can see that basal squamous, most of the cases are 0 to 1 and 2. So there's only one case has a 3+. Neuroendocrine-like, because we only have one small cell carcinoma in this cohort. So this case negative for uroplakin. And in the center is that this is the kind of a broad luminal type, including the stroma rich, luminal unstable, luminal non-specific, and luminal papillary. Most of the cases are 3+. Next. Here's another angle. Look at the data. Is 0, which shows the most of the cases are basal squamous, and so as the 1+ and the 2+, and the 3+, most of the cases are luminal type. Next. So here's a summary of all the staining in each particular molecular subtype. So again, the basal, most of them are 0 to 2%, 2+. and the nominal is most of them are 3+. So next question is how we set up the cutoff to do the best job. Next. So here's the performance. If we set up a cutoff as a 0 to 1+, which is basically positive versus negative, so we can find 95% of the nominal, but only have 56% of the specificity. If the cutoff is set up as set to at 1 to 2+, which is less than 10% or more than 10% of the tumor stain, so the specificity is 93%, and the sensitivity will be 93%, and the specificity over 81%. But if we set the cutoff of 50% of the tumor cell, which is 2+ versus 3+, and we'll have a sensitivity of 91%, and this very specific, and specificity of 93%, 96%. So it's pretty good for this. Next. So why we try and do this, and because this has clinical impact for the tumor. And then so let's Dr. Peter Black to discuss more about the detail in the clinical impact.
Okay, perfect. Thank you, Gang. I'm gonna skip over some of my slides just for the sake of time, so we have some time at the end for questions. There we are. The clinical context is neoadjuvant chemotherapy. I didn't really highlight it at the beginning, but this is all about muscle-invasive bladder cancer. And so muscle-invasive bladder cancer, we typically treat with neoadjuvant cisplatin-based chemotherapy followed by radical cystectomy. There's very good evidence for this, yet it's not widely done for different reasons. And one reason is that only 40% of patients actually benefit from the chemo, yet all 100% face potential toxicity. And it would, of course, be a lot easier if we could actually identify patients ahead of time, so we can prioritize chemo in those who are likely to respond and skip chemo and go straight to surgery in those who are not. And so there have been various approaches to this. I mentioned that the MD Anderson group in the initial publication of their subtyping scheme highlighted the potential impact on response to chemotherapy. And you see here in 3 relatively small patient cohorts that the P53-like cohort in the middle had a very low response rate. So this is pathologic response to neoadjuvant chemotherapy. And so we wanted to validate this, and we put together a NAC, so a neoadjuvant chemotherapy cohort. And some of these are the patients that Gang looked at that he showed you there with the markers. And we basically had a discovery set and a validation set, 223 and 82. And then we also put together a cohort of publicly available data for patients who did not get neoadjuvant chemotherapy so that we could make the comparison of outcome based on subtype with and without chemotherapy. Importantly, the Gang highlighted the idea of converting the subtyping to a simple IHC marker. If we stick to the transcriptomics, we still have to make it an individual patient classifier, single patient classifier, so that if you have one patient sitting in front of you, you can make the call. All of the schema that I've described actually had whole patient cohorts, and you had to do a clustering to identify subtype. So we developed a single patient classifier, and then we applied it to these cohorts. And you can see on the left-hand side of the screen, the non-neoadjuvant chemo cohort. And you can see in blue are the luminal tumors, which do relatively well. If you jump across to the right, the neoadjuvant cohort, the blue line is still the best with or without chemotherapy. So maybe these patients don't need chemotherapy because they have a favorable prognosis without. But the most interesting line to highlight is the red line, which is the basal subtype that does quite poorly on the left without chemotherapy, but then jumps up to a level similar to the luminal type on the right. And so we would say that the basal subtype is really a predictive biomarker that these patients benefit more with respect to chemotherapy. Now, this is a survival analysis. We did not see the same with pathologic response, which is a bit of a deficit in this data. Now, I mentioned that one idea is that luminal papillary does so well without chemo that they don't necessarily need it. And the idea is that they have a lower risk of upstaging. So you know that we struggle with clinical staging of bladder cancer, that we usually get it wrong and that they're often higher stage. So we wanted to look if that was maybe dependent on the subtype. And we did this. Yair Lotan at UT Southwestern led this project. It was multi-institutional clinical T1, T2 disease who did not get chemo, about half and half T1, T2, or 40-60. When you enrich for T1 patients like this, you get a lot more luminal. So almost 50% were luminal tumors. And of course, non-muscle invasive disease in general is more likely to be luminal. And you can see the likelihood of being upstaged in the absence of chemo to T3, T4 disease was about a quarter of the luminal papillary tumors and about half of the other subtypes. So we did validate the hypothesis in that sense, although the risk of having positive nodes in the bottom box was about the same, which again is a bit of a enigma why that is the case. But it speaks to the possibility that you could select out patients based on subtyping who may best be managed by going straight to cystectomy. I'm going to skip over this. There are DNA damage repair gene alterations that also predict response to chemotherapy, but we don't really have enough time to that. I just wanted to focus on a couple of trials that are being done. So this is oh boy, something funny happened to the arrows on that, but this is a concept that we're developing through SWOG. Josh Meeks in Chicago is leading this, where we classify the tumors into luminal papillary versus basal versus all the rest. And the standard of care treatment is neoadjuvant chemotherapy followed by cystectomy. And the luminal papillary, I just made the argument that maybe they don't need anything. But the other thing that they have, as I pointed out, is a very high rate of FGFR alterations. So the perfect group to test FGFR targeted therapy, which is approved in Canada in the metastatic setting. For the basal-like, we would compare to checkpoint blockade alone. And then the others, we would combine chemo plus checkpoint blockade. And there's rationale for each that I won't go into too much detail on. One trial that's already ongoing, the surgeon's perspective is how do we avoid chemotherapy? This is the medical oncologist perspective, which is how do we avoid surgery? And here are the patients. This is a Sloan Kettering-led trial through the Alliance, a cooperative group. They get neoadjuvant chemotherapy. If they have a DNA damage repair alteration, then if they have a clinical complete response, they keep their bladder. So they're using the DNA damage repair genes to select out a group of patients that can probably keep their bladder, because we know from the papers that I jumped over there that they have a high likelihood of actually having no disease left. If we don't select for DNA damage repair genes, we know that approximately 1/3 of patients where we think they had a complete response actually have residual muscle invasive disease. So the idea is that these alterations will predict those of a true complete response. So very interesting trial designs based on molecular characterization. I'm going to skip over this for the sake of time. There's some indication in trimodal therapy as well as neoadjuvant immunotherapy that subtyping can also be of benefit. And you can imagine a stratification based on the subtyping and the studies I just jumped over, that the basal subtype, those patients that get neoadjuvant cisplatin-based chemotherapy. The patients that are immune enriched but low stage will do well with trimodal therapy. Those are high stage immune enriched should get neoadjuvant immunotherapy. And the other subtype should go straight to cystectomy. So you can start to build a subtyping based treatment algorithm. You can see that I cheated a little bit by saying immune enriched, because in these two studies, the subtyping directly wasn't as predictive as looking at just immune signatures. But of course, they're closely related. So just a summary slide, so we have a little bit of time for questions. I think that molecular subtypes provides an important framework, especially in the lab right now. Everything we do, we always go back and ask, well, how does it fit with subtypes? But also potentially in the treatment of patients, although it requires clinical trial data to really validate that. The neuroendocrine-like subtype has a very poor prognosis, and it just speaks for the potential to define transcriptomic markers to identify other subtypes. The basal subtype has greatest benefit from chemo. the luminal pathway subtype has the lowest risk of upstaging and may not benefit from chemo. And all of this requires prospective randomized trials before we can actually use it in patients. And so I'd just like to highlight, I've done a lot of this work together with the group at Decipher Biosciences, which is a Vancouver company. I didn't have a disclosure slide at the beginning, but I do share a patent for the subtyping of bladder cancer. There's actually a marketable test, or a test on the market in the US, not available in Canada. And a lot of the cohorts come from various international collaborators. And I think Gang has an acknowledgement slide here at the end as well.
Yeah, so this is a collaboration with a lot of people, and so here's the main, some of the main helpers and around the in BC Cancer, MDNS, and the state.
Thank you very much, Gang. Thank you very much, Peter. It was a very informative talk, especially for me, who doesn't really know much about urothelial carcinoma, at least from a professional point of view. We do have a few questions, so for the sake of time, I'm just going to start asking you. The first one is for Gang, and it refers to neuroendocrine carcinoma. And the question is, what is the morphologic correlate for neuroendocrine-like group? Is it conventional urothelial carcinoma with neuroendocrine differentiation, or is it actually pure neuroendocrine carcinoma, large cell or small cell?
So I would say the pure neuroendocrine carcinoma, including the small cell and the large cell, will be obviously fall into this group. But sometimes the conventional urothelial carcinoma, like rarely, will have also have the signature based on the gene expression profile. In that kind of a case, I don't have a definite answer for how many, the percentage, and what exactly they look like. Because I will expect some of the cases will have a certain degree of neuroendocrine differentiation, such as express some of the neuroendocrine markers. But whether it's being called large cell, because if it's a small cell, it's more easy to be recognized. And the issue is some of the large cell neuroendocrine carcinoma, and I would expect it to be missed or underdiagnosis in the past. Because if it has a high grade tumor, if people don't appreciate that the features, morphological features, especially the granular cytoplasm and pseudorocyte and that kind of peripheral palisating, so it's quite often won't be recognized. So that's my suspicion, and yeah, so that's
your answer.
Okay.
Yeah. I have another question that's also for you, and it refers to immunohistochemistry for urothelial carcinoma. And the question is about the GATA3 CK56 pair. So that's the question. The conventional urothelial carcinoma that we encounter in primary and metastatic setting, it's usually GATA3 and CK56 positive, where in the classification that was presented, GATA3 and CK56 seems to be mutually exclusive. Could you comment on that?
I think that's the reason is not this panel of these two is not work that perfectly. And in the study from MD Anderson recently published, is that it is correlate 80% of the cases. So that's why I think if only call particular marker positive or negative, probably is not good enough to do that, especially for GATA3 and the CK56, the most quite common to co-expressed. But it depends on the density or percentage of the cells stained. So if it's basal and strong positive for CK56, and in that in those tumor, GATA3 might be weaker, but how weak they are and how many tumor nuclei stain, and so there's no cutoff for that. And the other way, and strong positive for GATA3, but it could have a focal staining for CK56. So this is no score algorithm or any cutoff for and define it. So that's how we think this is not a well-defined way to separate them. That's an issue. Yeah. So that's why we try to using a single marker. If we can use a single marker and a standardized and more clinical, practical score method to do the job, and that'll be great. That's our purpose.
Okay, thank you. And sorry.
Can I just say, Dan, as well? I think the molecular subtyping at RNA level, it's easy to assign tumors to bins, and then you think, okay, this one's luminal, this one's basal, whatever. But if you actually look at the gene expression of individual tumors, a lot of them are very close to jumping into another bin. And in many cases, it's not as clear as you would like it to be. And I think that if you're only looking at a handful of markers in immunohistochemistry, it's even more difficult to decide. You can use with the gene expression, you can actually give it a score of how basal is it? Is it 100% or is it actually just 50% and actually very close to something else? So it's trying to put sharp borders on these subtypes is very difficult.
Okay, thank you for that comment. For somebody that doesn't, like myself, I'm not doing geopathology, but I do primary unknown. And I think one practical comment that I would like to make regarding neuroendocrine carcinoma, it's that TTF1, it is really not useful for determining the anatomic site of origin for these tumors. I think most pathologists are aware of this. However, this is one of the mistakes that we usually see. History of bladder cancer, TTF1 positive nodule in the lung consistent with urothelial, just because of the history. So could you comment on that, Gang? I do not use TTF1 for confirming anatomic site.
That's true. Yeah, we don't use TTF1 and it has to be combined with other markers together. For neuroendocrine differentiation, it's if we really from the neuroendocrine tumor outside the lung, we usually not using it, unless we see the morphologically it looks like a neuroendocrine tumor, but negative for synaptophysin or chromoguanine. So we try TTF1 and all the new markers INS and INSM1. So this nuclear staining is better to interpret it, but we don't usually use TTF1.
Okay. Yes, thank you. And maybe one last question for Peter, although it looks like we have questions pouring right now, although we're a little bit late. So one question for Peter. Do any of the molecular subtypes show an earlier or a more aggressive metastatic behavior?
For sure. The neuroendocrine does, but it's such a small cohort, it's hard to study. But the basal subtype as the biggest subtype is definitely more aggressive. The more proliferative gene expression pattern. They are more metastatic early, as the question asks. So yes, I think it helps to stratify that risk.
Okay, and one last question, because I think the answer will be quick from Gang. Do you report urothelial carcinoma as luminal or basal type in addition to the grade, stage, and other parameters?
Not right now.
Okay. So I think it's already 11:02 and we're running out of time. I would like to thank you both for participating at the CAMPPODS today. And I would like to thank the attendees. We had 78 people that stayed for the length of the presentation. So thank you very much. Please do not forget to fill up the evaluations. They are very important for us, and also do suggest future topics. Thank you again to our sponsors, Amgen, AstraZeneca, Bayer Healthcare, Bristol Myers Squibb, Merck, and Pfizer for sponsoring the CAMPPODS for 2021. And I would like to welcome you all again in a month on March 4th, the first Thursday of the month, for the next CAMPPOD on the topic Nurse Navigator in Oncology, Luxury or Necessity, We will have one of our colleagues from the Cancer Agency, the registered nurse Kelly Zibrick, talking to us about her experience navigating thoracic oncology patients for the last 3 or 4 years here at the Cancer Agency. And she will really focus her presentation on pathologists and how pathologists can help with patients' navigation. So I hope to see many of you joining us again in March.